Hi, everyone. By now, we should have covered some of the main topics of some of the mechanisms that underlie acute pain. And remember from the prior lectures that really when we talk about concepts of acute pain, we're really kind of discussing a little bit in terms of terminology, where acute pain is not really what we're accurately describing when we talk about the physiological mechanisms that underlie pain after injury. Really, when we start to look at pain after injury, we're really discussing something called nociception. So nociception are the physiological mechanisms that warn of tissue damage. And remember from prior lectures, we've discussed how nociception and pain are not necessarily the same things. Nociception is an indicator of tissue damage. Pain is kind of a warning sign that something may be damaged, but also could be an indication that maybe tissue isn't damaged. So if we're looking at tissue damage, then really we're looking at the concept of nociception. Now, what we're going to be discussing are some of the changes that occur in people with chronic pain. Some of the changes that may be reflected in increased nociceptive drive, and sometimes some of the changes that occur in the cortical regions as well. So we're going to be dividing these modules into two phases. One phase is the peripheral mechanisms, and the second phase is going to be looking at the cortical mechanisms and subcortical mechanisms that may be involved in chronic pain, or also may be changed in people with chronic pain. So we'll be looking at that. So to begin with, we're going to be talking about the mechanisms of chronic pain as a result it relates to peripheral mechanisms. And if we start to talk about the mechanisms of chronic pain, really we know in most people that acute pain or nociception should resolve in about 6 to 8 weeks for most tissues. When pain lasts longer than that, or when people have symptoms longer than that, that is not normal. And so something has changed either in the perception or things have changed along the route of the nerves as they progress up to the brain. So all these things can occur as people don't heal quite as well, and as people start to get into more of the chronic types of pains. And so what we're going to be taking a look at is abnormal pain processing. So if you remember from the prior lecture on acute pain mechanisms, really there's four main responses or four main physiological changes that we see in people with nociceptive pain. So first is the changes that occur at the periphery, at the receptor level. And these changes are called transduction. So what it is it's converting a mechanical or chemical signal into an electrical signal that will be later transmitted down the course of a nerve. And so that occurs at the receptor level. And so the first part of the process is transduction. The second part of the process is conduction. Conduction is the process that are the peripheral nerves, say the C and A delta nerves. They begin to transmit information from the periphery and up towards the spinal cord. Once they reach the spinal cord, they synapse and they send signals up through the spinal cord. And what those signals as they transmit up through the spinal cord is called transmission. And then they finally reach subcortical and cortical levels where these signals are perceived. And so that part is called the perception component of things. So those changes that occur in the subcortical and cortical regions of the brain. And so we'll be alluding to these changes as we start to take a look at to the different mechanisms that change in people with chronic pain. So what happens with chronic pain? Well, really changes occur at all levels of pain processing. That's one of the most interesting things that we've been finding, is that we have begun over the last 20 years to really get a better understanding of some of the changes that occur in people with chronic pain. that occur at all different levels of pain processing. It happens at the transmission, the transduction, the conduction, and the perception levels of pain. And so we're going to talk about some of those changes. So in likelihood, as we start to progress and science starts to evolve, that these changes will be added on. And it is being added on almost on a yearly basis, some of the changes we see that occurs in the pain processing process. So we're going to start with transduction. So if you remember, transduction is the conversion of chemical or mechanical pressure into electrical signals. So of course these things occur at the tissue level. Now when someone's first injured, remember that there is an inflammatory process that occurs. And this inflammatory process involves the release of a lot of chemical mediators. These chemical mediators, what are their jobs are to signal to that tissue has been damaged. And part of that signaling process is to bring in tissue to help heal up the tissue that was injured. Part of it is also to facilitate action potentials down the nociceptive system so that the brain becomes warned and the person and the organism becomes warned of tissue damage and then can take appropriate behavioral responses. So you'll see that there's a whole host of different kind of chemicals that are actually released in the periphery as a result of injury. So things like hydrogen ions, norepinephrine, bradykinins, histamines, potassium, prostaglandins, purines, cytokines, leukotrienes, nerve growth factors, neuropeptides. All of these are released when a tissue is injured. And so this is all part of the natural nociceptive response. The goal of these responses, if you remember, is to go ahead and increase the sensitivity of the nervous system, the nociceptive system. And so what happens, it helps to bring down the threshold. And it does through a number of mechanisms. Some of them open up the sodium-potassium gates. Some of them activate fibers or neurons, nociceptive neurons that were previously silent. And we'll talk about those things now. So the interesting thing is that a lot of this whole host of inflammatory mediators that are released, they are more prevalent and stay around prevalent in people with chronic pain. And so one of the things that we find a lot of times in people with chronic pain are an influx of inflammation that occurs in the periphery. And this influx of inflammation, as it stays around in the periphery and around the receptors longer and longer, what happens is it has a tendency to keep those neurons thresholds at a little lower rate. So they keep some of the channels open longer, and so the normal threshold rate required for activation of an action potential is lower, so it's a lower threshold, and so it makes it easier for these neurons to be activated. And you'll see in this one where you can see damaged cells will release things like mast cells and macrophages in the area of tissue damage. And so as the damaged tissue is signaling these different mast cells and neutrophils to come into the area, you'll see that they release a host of these chemical mediators. The macrophages will release things like bradykinins and nerve growth factors. And the mast cells will release things like bradykinins and histamines and serotonin. And all these, you can see, have the effect of altering the resting state of these neurons. There's also an inflammatory spread that occurs in people with chronic pain. So what's an inflammatory spread? Well, if you look at the neurons on the right, you'll see that typically when something's injured, it'll start by activating and facilitating the recruitment of a nociceptive neuron. So you'll see the receptors, the channels will begin to open. As they open, it'll change the threshold, and as the threshold increases, or as the threshold reaches critical areas, what will happen is it'll send an action potential down the neuron, and you'll get nociception. What we find in people with chronic pain is that this inflammation starts to spread to other areas and activate other neurons in the area as well. And this is called inflammatory spread, as it starts locally and the inflammation starts to affect the nociceptors in adjacent areas. We'll also see changes at the receptors level. So C fibers, we have a tendency to think of them as nociceptive fibers. And they are nociceptive fibers, but also you have to realize that they have roles that go beyond the transmission of nociceptive information. Remember, these C fibers, most of them, will go up and activate areas into the spinal cord, which then send information up to the subcortical regions of the brain. And so a lot of times these C fibers are not nociceptive in nature, in the fact that let's take a step back. They are nociceptive in nature because they're warning of tissue damage, but their direct cause or their direct action is not necessarily to cause pain, because they don't go directly up to the cortical regions of the brain, which are responsible for pain perception. Instead, they stop at the subcortical regions, which are more responsible for autonomic responses and behavioral responses. And so we'll see these communicating fibers, these silent C fibers. What will happen is before they just serve the role of communication through the body. But we'll find in people with chronic pain that these C fibers get hijacked and they become nociceptive fibers, and they start to send information up to the pain areas of the brain. So these prior silent C fibers become activated. And the interesting thing about these C fibers, they do not shut back down in people with chronic pain. They stay active and they stay recruited specifically for nociception. In these silent C fibers, how does that occur? Well, a lot of times what they'll have is the sodium-potassium pumps will be blocked or plugged. And what happens is chemical mediators such as glutamate or substance P, what they do is open up these sodium-potassium pumps, and the NMDA mechanisms activate previously silent C fibers. And so what occurs is that these previously silent C fibers, meant only for communication, begin to open up, and the plugs that were in the channel become unplugged through substances like glutamate and substance P. And we find that they don't shut back down in people with chronic pain, where in people with acute pain, they'll shut back down. So what are some of the changes that we find in the peripheral nerve? Well, prior discussions, we were talking about things that happened at the periphery, at the receptor level. So we were talking about changes that occur with transduction. Now we're looking at changes that occur in the peripheral nerve. So really we're talking about changes that occur with conduction. Sometimes these changes that occur with conduction, since they occur in the peripheral nervous system, are called peripheral sensitization. Peripheral sensitization meaning that the nerve becomes more sensitive, or the threshold of a nerve becomes lower, so they're more easily engaged. So there's several processes sometimes can occur that are kind of reflective of peripheral sensitization and how quickly a nerve is activated. One of these is something called temporal summation, or sometimes called wind-up. Now, if you remember your neurophysiology, what happens when a nerve is activated or stimulated? Sodium-potassium channels are opened up like we discussed. And as they open up, what it does is changes the polarity that occurs at the receptors. Now, one single change in a receptor is probably not enough to make a major change, because if you remember, that nerves have a threshold, a resting threshold, and then it has an activation threshold. And so what happens is a single channel may bring the resting threshold closer to the activation threshold, but is not enough for it to fire. What happens with the increasing recruitment of different sodium-potassium channels is that as each one is activated, then the resting threshold gets higher and higher and higher. So soon it reaches the same level as the activation threshold. And as the activation threshold is reached, an action potential is propagated down the length of the nerve. You also remember that after this occurs, there's a phase of depolarization and there's a phase of repolarization. Now, generally during repolarization, what happens is the resting threshold resets and goes back down to the normal resting threshold. This occurs if you activate a nerve and give it ample time to repolarize. But what happens if you activate it before it has a chance to completely repolarize? Then what happens is the resting potential never reached its lower level, it's at a higher level. So it takes less opening of sodium-potassium channels, less stimulation for the nerve to refire again. And we find that if you repetitively recruit the nerve before it gets a chance to repolarize, it takes less and less and less of a stimulus in order for activation to occur. And so that's what you see in the pictures below. Now, this is one of the theories behind peripheral sensitization. They feel that in some patients, because nerves are continuously active, or in some patients because silent C fibers or sodium-potassium channels have become unblocked, what happens is the resting potential is closer to the activation potential. So if this occurs long enough, then what will happen is that it will take less of a stimulus in order to recruit the nociceptors. So it'll take less pressure, less chemical mediators to go ahead and recruit the nociceptors. And they believe that this kind of occurs in people with chronic pain. There's maybe some type of temporal summation that may be occurring in the periphery. There's also changes that occur along the axon. And so if you remember what a peripheral axon looks like, you'll see that's really a bundle of nerve as well as blood vessels, but they're all surrounded by myelin. And so the interesting thing is that as we start to get changes along the axon, they impact the activity of the axon itself. So what are some of the changes that we see along the axon? Well, one of the major changes that we see, and this is really relatively newer science, is the impact that glial cells have upon the peripheral nervous system. Now, we'll be talking about this in more depth when we start to talk about changes that potentially occur at the cortical levels. But if you remember, glial cells are kind of the body's support cells. And so the role of the glial cells, what they do is they come along and they help support the activity of different structures. And most often they support the activity of nervous systems. And a lot of times what we do is we have a tendency to focus on the nerves themselves without realizing that glial cells, what they actually do is very important. They maintain and keep the health of the nervous system. Now, there's multiple types of glial cells that we'll talk about later. The one we're talking about here is actually microglia. Microglia is a type of glial cell, and what its job is to deal with injury and illness, and it does so because it has kind of an immune response as well as a healing response. And so in the picture below, you'll see some things that we're learning about glial cells. And they're thinking that chronic pain may be caused by nerve damage brought on by illness or injuries. So these are the first instigation of an injury. But what makes it become more chronic in nature? Where they're thinking that the damage activates in certain people the spinal cord microglia, and they in turn release a certain protein. And that protein that causes the spinal neuron to send abnormal signals of pain processing to the brain. And so they're thinking that this microglia, which its job is to go ahead and deal with damaged tissue, and it instigates an immune response in that area to help the nerve fight off foreign invaders, but also helps to signal the need for an area to heal. What happens to people with chronic pain is that it releases a certain protein, and this protein, what it does is it changes the activity level or the signaling capacity of the nociceptors. And so what it does is instead of turning on a pain suppression system, it turns it into a pain amplification system. And so how does it do that? Through peripheral sensitization, the process of changing the threshold of activation for these neurons. And so that's one of the things that we find that glial cells can do, is it changes the neuronal firing patterns. But in addition to that, remember there's a certain type of glia that's not listed here, and the type of glia is called a oligodendrocyte. And the specific type of oligodendrocyte we're talking about is actually a Schwann cell. So if you remember, in most peripheral nerves, especially the A delta nerves, not so much the C fibers because they don't have Schwann cells, or they don't have a myelin sheath around it. What happens in these cells, especially the A delta cells, is that the Schwann cells are actually damaged. And so these Schwann cells, for some reason, don't necessarily get repaired in the periphery. And so what happens is they then allow for an easier activation in those specific areas. And we'll talk about that in a second. So beyond the changes that occur actually through the glial cells, we're also seeing that there's potentially changes that occur within the nerve themselves. If you remember, primarily what happens is that nociceptive neurons are the C fibers and the A delta fibers. These are classically known as nociceptive-specific neurons. Things like A alpha, A delta fibers, or A beta fibers, they're typically more of a sensory fiber, and their job is to send sensations up to the brain. What we're finding is that in people with chronic pain, that these different types of cells that are normally responsible for transmitting information about sensation start to change their makeup, so then they get recruited to become nociceptive neurons. And so the function and the characters of these sensory fibers begin to take on the function and characteristics of nociceptive fibers. So those are some of the changes that occur at the periphery. The one change that I start to talk about that's not really listed here is also the damage that occurs at the glial cells or the Schwann cells. There's a process that is called ectopic pacemakers. And so what occurs in these ectopic pacemakers, these areas that become areas of ectopic pacemaking, is that normally nerves can only transmit information if the receptors are activated, and then at the axon hillock, the action potential or the stimulus reaches a point where it hits the activation threshold, and then action potential is propagated. This usually occurs from the receptors to the axon hillock and then up the nervous system itself. You guys remember that process. But what happens in people with chronic pain, we find that sometimes the nerves themselves are damaged along the axon, where the Schwann cells are damaged, and so the sheath itself, the myelin sheath, becomes damaged. And what ends up happening at those areas where the myelin sheath is that they become places where an action potential can begin. And so these become areas that they call etopic pacemakers, where no longer is the activation occur at the receptor level, but it occurs along the length of the nerve itself. And we find that occurs in people with chronic pain, whereas normally that area is healed up in people without chronic pain. So what are some of the changes that occur at the spinal cord and involve the process of transmission? So we've covered the process of transduction, we've covered the process of conduction, and now we're looking at the process of transmission from the spinal cord to the brain. So remember we talked about central or peripheral sensitization, the process by which the peripheral nerve becomes more sensitive to activation. Now we're looking at the process of central sensitization, and the process of central sensitization results in similar ease of activation of the different systems, of the neurons in those systems, but the mechanisms are slightly different than the periphery. So what we're finding in people with chronic pain is that changes occur in the spinal cord and also the brainstem and the cortex of the brain. Right now we're just going to be talking about those changes that occur in the spinal cord. So what are some of the changes that occur in the spinal cord? Well, normally, if we remember, pain is primarily transmitted once it gets to the spinal cord up the laminas 1 and 2. You'll see that on the picture in the left. Okay, those areas on the left 1 and 2 are specific for neurotransmission. So the A delta and the C fibers will synapse, and then from the synapse it'll send their fibers up the tracks 1 and 2. What we're finding in people with chronic pain is that areas 3, 4, and 5, which are more responsible for sensory information, what we're finding is those areas, neurons that synapse and travel up the spinal cord through those areas, are starting to sprout and branch into 1 and 2. And what's the importance of that? Is that these normally sensory pathways begin to send signals up the pain pathways. And so when it reaches the brain and the subcortical regions, it can't tell the difference of whether it came from a sensory fiber or if it came through nociceptive fibers. And so in that way, sensory fibers then begin to start to activate the nociceptive pathways. So once again, this is a little more detailed picture of what happens. So once again, lamina 1s and 2, which is called the substantia gelatinosa, they're responsible for A delta and C fibers or nociceptive transmission. You'll see laminas 4 and 5, and sometimes 3. They're responsible for more sensory. And you can see in that picture how those areas start to sprout or branch into 1 and 2. And then sensory, like we talked about, sensory information then becomes interpreted by the brain as nociceptive information. So that's the end of this particular module on peripheral mechanisms and changes that occur in chronic pain. We're learning more and more about the changes that occur in the periphery each and every year. So in likelihood, if you keep up with the literature, you'll see additional information to come.